Good evening, everyone, every member of the Nigerian Society for Colorectal Diseases. Please permit me to, I've seen some very senior people here, some of my teachers. I need to greet them before I go ahead. I must greet Professor Lofa Chidan, Professor Benjamin Enugu. These are very senior people, the ones I can recognize. I greet all of you, sirs. And I think I also saw Professor Eleweke. Good evening, all. Thank you for this opportunity. So this evening, we'll be discussing anorectal malformation. This is as a mixed audience. So at the end of the presentation, if there are questions, you ask, and I believe I'll be able to do that. So I may not, from the presentation, meet everybody's need, but I will go to as far as I can to highlight this important topic. So I want to declare that I don't have any conflict of interest, and this is for purely academic purposes. I'll use this outline, but it may not be followed strictly. So anorectal malformation. Anorectal malformations are a spectrum of congenital anomalies, and they have variable complexities involving the anorectum and the lower urogenital tract. Though here, more of our emphasis is on the anorectum, since we are talking about colorectal diseases. But it's good to know that there may be also some urogenital components to it. Embryologically, the anorectum and also some of the tissues of mesodermal origin, like the muscles, the bones, the sphincters, and the pelvic floor muscles are also involved in the anomaly. The exact etiology may not be known, and most of the patients will present in the neonatal age group or early infancy, though few present in adolescent period, or like I will present a case later in this presentation in adult age group. They constitute the commonest cause of neonatal intestinal obstruction and commonest indication for colostomy in children. Most are non-syndromic, and they form part of the VACTAL association. We hear about this a lot. So that anorectal, or A in the VACTAL, is for anorectal malformation. Though it's generally a clinical diagnosis, adequate investigations are necessary to define the exact anatomy and plan for surgery. This is so important because there are various anatomical variations. So you need to know exactly what type so that surgery can be adequately planned for. So at the end, a well-placed anus with fecal and also urinary continence is the ultimate aim of treatment. Assessment of outcome and follow-up are also very important. So most anorectal malformations are isolated and not associated with syndromes, though there are a few familial cases, and also sometimes may be associated with polycontrolled maternal diabetes and IVF. So generally, most of the patients will present in the neonatal period as intestinal obstruction, with all the associated physiological and pathological changes that go with intestinal obstruction, which we'll not go into in details now. Patients with perineal fistula and vestibular fistulas may present with chronic constipation rather than complete intestinal obstruction in the neonatal period. So this may make them to present later in life or even in adulthood. Fecal contamination of the urinary tract can be a problem when there is a fistula, like in many cases, especially males. So if there's fistulation to the urinary tract, the urethra, the bladder, it may present with urosepsis. Then also the presence of the different associated anomalies, which may be in the urinary tract like vesicoureteral reflux, duplex renal system, renal dysplasia, hypospadia. Then, especially in patients with colorectal anomaly, there may be hydrometrocorpus, duplicate vagina, and uterus. Rarely, Hirschsprung disease may be associated with anorectal malformation. There are this triad of anorectal malformation, sacral deformity, and presacral mass, which is not common, but may be found. So embryologically, the cloaca forms in utero, so where the hindgut and also the urogenital tract end in a common cavity, embryologically. Then after that, then there's a septation of the cloaca into anterior by the descent of a mesodermal wedge, that is the urorectal septum. So it divides the cloaca into anterior urogenital sinus and the posterior anorectum. When this meets the membrane, that's the cloacal membrane, then the cloacal membrane will break down to now form the urogenital membrane and the anal membrane. Then the anal canal is actually formed by, the upper third is derived from the endoderm, while the lower third is of ectodermal origin from the invagination of the proctodium. So this is just trying to show the septum, the urorectal septum, descending from here to here to here, down to the cloacal membrane to separate into the urogenital sinus and the hindgut posteriorly. So when there's abnormality of this normal embryological development, like if the urorectal septum, either completely or incompletely descends, it can lead to various types of anorectal malformation with fistulation to the urinary tract. If there is no descent at all, then you have what is called cloacal anomaly. Then recently, it has been also thought that a shortened dorsal cloacal membrane may also contribute to anorectal malformation. Then failure of the proctodium will prevent development of lower one-third of the anal canal. This anorectal malformation generally occur in about 1 in 1,500 to 5,000 live births. It's the commonest cause of intestinal obstruction in neonates and commonest indication for childhood colostomy. It's a bit more common in males. Then in females, the most common anorectal malformation is rectovestibular fistula, where there is anorectal malformation with fistula to the vestibule, posterior to the vaginal opening. We have seen a lot of cases where diagnosis of rectovaginal fistula is made in such a case. Rectovaginal fistula as a part of anorectal malformation is a rare anomaly. So what we see more commonly is rectovestibular fistula. Then in males, is most commonly rectourethral fistula at the level of the bulbar urethra. At least 60% of such patients will have one associated anomaly. Though generally, anorectal malformations of the high type are associated more with associated anomalies than the low types. So the most recent classification, though not so recent, almost 20 years ago, is the Krickenberg classification. Most of these classifications are just like a Delphi process where experts from different parts of the world gather and take decisions. So that is actually how this classification was started in Krickenberg, Germany in 2005. So why is important here is that the Krickenberg classification emphasizes precise anatomy instead of broad classifications like into low, intermediate, and high. Then this helps improve surgical planning, standardization of outcome assessment, and prediction or assessment of outcomes. So it divides the anorectal malformations into major groups and rare variants. Before Krickenberg, there were also Melbourne in classification in 1970 and Wingspread in 1984. So this is a summary of the Krickenberg classification. So the major clinical groups will include the perineal fistulas, rectourethral, rectovesical, vestibular, cloacal, anorectal malformation without fistula, and anal stenosis. Then the rarer variants or regional variants are now lower down. So you can see that rectovaginal fistula is one of the rare anomalies. So I've shown a pictorial representation of some of the common anomalies. So I'll just quickly show the anomalies. For example, this is a male with a rectoperineal fistula. If you look closely, you can see where the sphincter complex is, but the fistula is actually anterior to that point. So this is where the normal anal opening, or anal canal and anal opening should be, but it's now anterior. Then this is anorectal malformation with recto-bulbourethral fistula. Okay, so at the same thing, the rectum has not, anorectum is absent at this point, but there's a fistula into the urinary tract. Then higher up, you have rectoprostatic fistula. Anorectal malformation with rectoprostatic fistula. Then this one is fistulation to the bladder neck. You can see this is quite high. So the higher the anomaly, the less developed, the more associated anomalies, the less developed the sphincter complex. So in females, you can see the rectovestibular fistula. This is rectum to the vestibule. So in this case of rectovestibular fistula in female, clinically, you will see 3 openings in the perineum instead of the normal 2, the urethral opening and the vaginal opening. There's a 3rd opening within that vestibule. So that gives it away. So the patient will be passing through here. But the patency of the fistula may not be adequate to completely decompress the rectum and the gastrointestinal tract. So they can present with intestinal obstruction, especially in the older children when they are weaned into adult diet. So this one is fistula to the perineum, rectoperineal fistula, a bit more posterior, not in the vestibule, but anterior to where the anal opening should be. Then this is a cloacal anomaly. So in this case, there's one channel, the common channel. It may be a long common channel when it's more than 3 centimeters in length, or short common channel if it's less than 3 centimeters in length. So you can see that the rectum, the vagina, and the urethra all empty into one. So there's a single perineal opening, both in the vestibule and anywhere in the perineum, a single perineal opening. So that is cloacal anomaly or persistent cloaca, like we explained earlier in the embryology. So in anorectal malformation, these days there's a lot of emphasis on prenatal diagnosis in most congenital anomalies, but it's not common to have a prenatal diagnosis here. But if it is done, it may help to plan for early postnatal treatment. Though most cases of anorectal malformations are made postnatally, and like I said earlier, the diagnosis is mainly clinical, though investigations will help to further elucidate the various anatomical types. So the presentation may be in the early neonatal period where the patient may present with intestinal obstruction or passage of stool through an abnormal site. For example, I mentioned rectovestibular or rectoperineal, or sometimes patient may pass meconium in urine, or there will be pneumaturia, as the case may be. In some patients that present with anal stenosis or rectovestibular fistula or rectoperineal fistula, they may present later because there may not be any urgency because of intestinal obstruction. So they may present later in neonatal period or in later infancy. So when I mentioned the rectoperineal fistula, I thought it wise that it should be important at this point to differentiate between ectopic anus and perineal fistula. From the picture I showed earlier, you could see that the rectoperineal fistula, that the fistula opening is anterior to the normal site of the anal opening. And if you looked more closely, that perineal fistula didn't have any surrounding sphincter. So that's actually the basic difference. For an ectopic anus, the anterior ectopic anus is more anterior than normal, but surrounded by its sphincters. So that on a physical examination, you could see the normal puckering due to the surrounding sphincters, unlike a fistula, where there is no associated sphincter around it. So on examining the patient, you should also look for different associated anomalies. Like in fractal association, there may be associated cardiac anomaly or vertebral anomalies. Those are the two main associated anomalies in those fractal association. So it's important to also examine the perineum and look for the number of openings. Like I mentioned, the vestibular fistula will have 3 openings. In the normal case is 2 vestibular openings. So like in patient with rectovaginal fistula, the female, you may have 2 openings and the stool is actually coming exactly through the vaginal opening. Then when it is a single perineal orifice, then in the vestibule, then that is a cloacal anomaly. Sometimes in cloacal anomalies, there may be hydrocorpus or hydrometrocorpus due to accumulation of fluid within the sometimes very distended and even palpable vagina.
Vagina of Bluetooth.
Hello? Any problems? Can I go ahead?
Yes, go ahead, sir.
Okay. So sometimes they may present with a lower abdominal mass arising from the pelvis. Then also you talk about flattened buttocks and perineum. So these are some of the findings on physical examination. So to encourage early diagnosis of these patients at birth, we have seen cases where a patient was delivered in a properly constituted hospital and was discharged home only to come back after a few days with anorectal malformation. So that shouldn't be. So that is why adequate examination immediately after delivery should be encouraged so that such scenarios should not play out. Many times we talk about this prone cross-table lateral X-ray. Initially it was done as lateral invertogram, but that has been overtaken by prone cross-table lateral X-ray. So that is why I will, in a short while, show a picture that will suggest that. But most times, if it is clear that a patient requires intervention, like a patient that comes with intestinal obstruction, abdominal distension, one will not go doing this prone cross-table lateral X-ray because it is obvious that the patient already requires intervention. But when it is not clear whether you want to do a colostomy or not, then you can actually do this to help answer that question. Abdominal ultrasound may help to identify and estimate the sizes of this the hydrometrocorpus, and also identify some anomalies. It's important as an association to assess for spinal anomalies like tethered cord, which is the most common, either using spinal ultrasound if the patient is less than 3 months or spinal MRI. 2-dimensional echocardiography is also important, especially to identify VSD and SE, which are the most common anomalies, cardiac anomalies associated with anorectal malformation. So in fact, it's encouraged that any patient that has anorectal malformation should go for 2D echocardiography and also screening for theta cord. To help prognostication, there's what is called the sacral ratio. So if you look at this X-ray now, you find the ratio of YZ, which is a distance from the lower aspect of the sacroiliac joint to the transcristal plane all over. This is YZ is from the lower aspect of the sacroiliac joint to the tip of the coccyx over from the transcristal plane to this point. So the ideal ratio should be about 0.7 or 7.4, 7.7 as the case may be. So if a patient has loss of sacral segments, then the patient will have a very low sacral ratio, and that is a poor prognostic sign in terms of development of the pelvic muscle sphincters and also continence after surgery. So it helps prognostication. Then if a patient has already done, if a colostomy has been done on a patient, then there's a study called pressure augmented distal colostography, which will help to identify the local anatomy, show the site of the fistula if present, or say whether fistula is present or not. So that will also help. Sinogram can be done in cloaca or endoscopy of the single perineal opening. That will help to estimate the length of common channel. Perineal MRI can help to assess sphincters, the sphincter distribution and relationship to the rectum, and also the volume of the sphincter muscle complex. In fact, some people are now proposing use of perineal MRI as during surgery to actually help identification. But what is more commonly used is use of muscle stimulators to identify the muscles. Because the essence of the pull-through procedure or posterior sagittal anorectoplasty, as the case may be, is to make sure that the rectum passes through the center of the muscles to ensure, continence afterwards. So we talked about cross-table lateral X-ray earlier in the prone position. So this study is usually done when it's needed, at least 16 to 24 hours after birth, so that the swallowed air by the newborn gets to the most distal point of the patent anorectum. So this is PC line. This line runs from the pelvic bone. At that point, it may just be the ossification center to the last ossified bone along the vertebral column. They now draw another line parallel to the first one through the ischial tuberosity or the ossification point of the ischial bone. So if so it's generally used to say whether it is low, intermediate, or high anomaly. So if the most distal bowel gas shadow is proximal to this PC line, then it's taken as high. Then in between the two lines is intermediate, and distal to that is taken as low anomaly. Though, like I said, currently emphasis is more on anatomical types. So coming to the treatment, for example, a patient that requires colostomy, like a neonate, the colostomy can be done in that neonatal period, like in patients with obvious intestinal obstruction. Sometimes when they come later, at whatever age they present, depending on the anatomical type, colostomy may also be done. So when the surgery is done at around that time, that is the colostomy, then the definitive posterior sagittal anorectoplasty, which is the most common type of surgery that is done for anorectal malformation worldwide, can now be done between 6 months and 1 year. Then after the healing has taken place and you ensure that there's adequate patency of the new anus, then colostomy closure can be done. Before we go ahead, I also want to say that there are some low anomalies that traditionally may not require colostomy, like if there's an anal membrane or bucket handle deformity, this can be excise and dilatation done. In anal membrane is actually an incision, like make a cruciate incision in the membrane and dilate afterwards. Then if it's a bucket handle deformity, sometimes associated with anal stenosis. So after excision, the serial dilatation is done. Some do cutback anoplasty, but because of the cosmetically poor outcome, it is discouraged. So then we may not go into details of all the procedures, but I will mention them. So you do what we call total urogenital sinus mobilization, for short common channel cloaca, where the rectum is brought down separately, but the urethra and vagina are mobilized towards the perineum as a single unit, so that there is now sutured to the perineum. But in the long common channel, what is done is posterior sagittal anorectal ureterovaginoplasty. In patients with rectoperineal fistula or rectovestibular fistula, some may prefer to do what is called anterior sagittal anorectoplasty. Okay, we must remember that after a new anus is created, that anal dilatation program post-operatively is also very important. I just wanted to show this picture of the classical posterior sagittal approach to different types of anorectal anomalies. And most of these surgeries I've mentioned, like the posterior sagittal anorectoplasty, total urogenital mobilization, posterior sagittal anorectal ureterovaginoplasty, they're all done through the posterior sagittal approach. So that posterior sagittal is just the approach where you go through the posterior mid-sagittal plane. So, but the details of the different types of surgery is different depending on the type of anomaly. So just to talk about some few details of the surgery. So the posterior sagittal approach was popularized by Abotopina and De Vries in 1982. So it's important during this procedure to identify the sphincters. So like using muscle stimulators, or when it's not available, use of maybe low set pinpoints diatemy may actually show the muscle contractions at the skin level, just deep to the skin. Then as you dissect further inside, you can also use it to identify the muscle. So it's a very important step in this posterior sagittal anorectoplasty. So the incision must be mid-sagittal, from the skin to the rectal pouch, because there's less bleeding when you maintain the midline. When you leave the midline and go into either of the sphiorectal, into the sphiorectal part of fat, then there may be more bleeding. So the mobilization of the rectum must be full thickness, because in some types of anomalies, like maybe recto-urethral fistula, there may be some common wall between the rectum and the urethra for some distance. And in that case, you may go submucosal. But after that, always ensure that the full thickness of the rectal wall is mobilized. Then when the rectum has been mobilized adequately, preventing any form of devascularization, which may lead to strictures, then the rectum must pass through the sphincters. In fact, not just passing, the sphincter should be attached to the rectum during that process. That may also help to anchor the rectum to the lateral pelvic wall and prevent prolapse. Then the anoplasty is done. It's important if there's incision of the perineal body that it should be repaired. It's also important to remember that in different types of anomalies, like higher anomalies have a poorer developed sphincter complexes or muscle complex. So such may be communicated to the parents before the surgery, so that if there's incontinence after surgery, they should be carried along and all that. So that is it about some of the details of the surgery. I've talked about, currently people are, for the more complex anomalies like maybe cloacal anomalies, where the long common channel type. Some are encouraging centralization of care, where such maybe in each region of the country, as the case may be, maybe a hospital will be chosen with the most experienced person doing that. Then laparoscopically assisted transabdominal bowel mobilization when available. Like in the very high type anomalies, like cloacal malformation or rectal bladder neck fistula, there may be some form of transabdominal approach, whether open or laparoscopically, so that the bowel will be mobilized. Then currently, apart from the classical posterior sagittal anorectoplasty, where the length of the incision is from the tip of the coccyx, moving anteriorly to where the fistula is, in some form of anorectal malformation like recto vestibular, rectoperineal, one may use limited or minimal posterior sagittal anorectoplasty. I've talked about real-time MRI during surgery, which is now where it's available. Mostly is not available in our environment. We're discussing current concepts. So those are some of the current things, but we may not have them. Also talking about robotic assisted procedures. I've emphasized how important muscle stimulators are in anorectal malformation. It cannot be overemphasized because it's a good guide. We have seen cases where after anorectoplasty, when the patient came with some complications like fecal incontinence, you see that the muscle did not surround the inner opening. Trying to stimulate the sphincters, you just see that muscle contraction will be on one side, while on the other half of the inner opening, there are no sphincters. So that's why it's important to make sure the muscles surround the inner opening. If possible, depending on surgeon's experience, primary anoplasty without colostomy can be done. But each individual surgeon must do what he has adequate experience with. So that's why I said that stage procedure is still the treatment of choice in the higher anomalies. The bowel management programs, as needed, may also be helpful in managing these patients post-operatively. So when surgery is done, some of the complications that may occur may include fecal incontinence. I've emphasized that. Constipation, which may be from anal stenosis. So we make sure that the neo-anus is adequate. Sometimes there's anal dilatation program to make sure they remain, patent. In few cases, we have had anorectal malformation or head-sprung disease diagnosed when constipation persisted after posterior sagittal anorectoplasty, and biopsies were taken, and aganglionosis was noted, leading to further surgeries to excise the aganglionic segment. Anastomosis can break down, leading to retraction. And also, if it's not well anchored, there may be prolapse. So the knowledge of some of these complications will help one to plan and prevent them as much as possible. So just as I've mentioned that anorectal malformation is the most common indication for colostomy. So I just put one or two slides about colostomy and what is the preferred type of colostomy in anorectal malformation. Previously, people used to move away as far as possible from the anus, going to do maybe transverse colostomy, and some do loop colostomy. But it's been shown that divided colostomy is preferred, especially when there's suspected fistulation with the urinary tract. I know some people will say that you can actually construct loop colostomy to be, effectively defunctioning, not allowing, stool to go distally. But for many pediatric surgeons, we prefer to do a divided colostomy because there's always a risk of continuous soilage of the urinary tract by feces if the distal loop is not adequately defunctioned. Though loop colostomy is easier, but it's fraught with more complications. Then comparing sigmoid to proximal, comparing transverse colostomy to proximal sigmoid colostomy. Sigmoid colostomy is always better. Though in very high anomalies, one has to do it as proximal as possible so that you have adequate length to mobilize to the perineum. So, but generally, sigmoid colostomy is better because the distal bowel preparation is easier because you have a shorter length of bowel. Then in very long distal loops, urine absorption can be significant because if there's a fistula, as the patient is passing urine, some are flowing and some are going back into the rectum or the colon, distal colon, and can be reabsorbed significantly to cause metabolic acidosis. Then when one is doing pressure augmented distal colostography, it is easier with because the amount of fluid, the amount of pressure that is needed to really, achieve adequate pressure to show the distal anatomy is easier with sigmoid colostomy than transverse colostomy. Then skin care is easier too sigmoid in the sigmoid is more formed than in the transverse colostomy. So with all these, sigmoid divided colostomy seems to be the most acceptable type in anorectal malformation when colostomy is required. So concerning outcomes, also the Krinkenbach classification also developed a system of outcomes, basically assessing voluntary bowel movement, constipation, and soiling. Usually for children, this assessment is done at least in a 3-year-old. So even if the surgery is done at 1 year, this general assessment of outcome using the Krinkenbach system is done at about 3 years. So you check for voluntary bowel movement. Does the patient have the urge to pass stool or not? And to verbalize it and hold the bowel movement till a socially acceptable place. Then soiling can be grades 1 to 3. So is it grade 1 where it's occasional, maybe once a week, or when it is daily, but not a social problem to the patient? Okay, maybe managed with diet or toilet training. But if it's a constant soiling, as in grade 3, and is a social problem, some form of bowel management or sometimes reduced surgeries can actually be done. And also sometimes, if nothing else can be done, then Malone antegrade continent enema can be done, where enema is given in an antegrade fashion to keep the rectum empty for most times. Then constipation. I've listed the possible causes of constipation. So whichever one it is should be handled. But that is a way of assessing for constipation. So then comes the presentation in an adult I talked about earlier. So sometime last year, my unit had a case of a rectovestibular fistula in a 24-year female. So maybe due to some social problems, poverty and all that, she didn't, from the history she gave us, she didn't really have adequate or go to hospital until there was a free medical or surgical outreach where she presented to some adult surgeons who did a right transverse colostomy and now referred. So when the patient came, she came with a rectovestibular fistula and, soiling and a lot of things. Then, but what was very obvious was that the abdomen was distended. On examination, you could palpate a very large fecaloma almost to the fundus of that, fundus in quote, okay, almost to the level of the umbilicus. Okay, then, so when we, so that made us consider, the approach, because the size of that fecaloma is not possible to come out through the neoanus. So doing a posterior sagittal approach may have made it difficult because we may need to have turned the patient severally, which we didn't have the luxury of doing intraoperatively. So that was what we saw. You can see the rectum, the sigmoid has lost the tinea coli, the muscles are just stretched out, so massively dilated. So this was the fecaloma we retrieved from the massively dilated sigmoid and rectum. We weighed it, was like 2 kg. So it was retrieved through a longitudinal incision. So you can see after the retrieval of the large fecaloma, you could see how dilated the sigmoid was really massively dilated. So we did what, this is the final picture, but we did this surgery with the patient in lithotomy position. So you can see the rectovestibular fistula site. Okay, that's where the fistula was. Then this is the inner opening. So we made an incision both at the site of where the sphincter, we identified the sphincters, then made the incision through there and mobilized through the abdomen, and now disconnected the fistula. And this is the, the anastomosis to the skin. So that's the neoanus. Because of the massive dilatation of the rectum, and we felt that there may be some loss of function, we need to rest it to regain the tone. We are yet to close the colostomy. So we'll close it at least. I can't remember exactly when this was done, but we plan to close it. So that's the final picture of the patient. So just to summarize the issue of current trends. So I mentioned that where possible, less invasive procedures like laparoscopic access to the abdomen or laparoscopic mobilization where available, then the minimal or limited PSAP when necessary. Instead of always making a very long incision, incision can be reduced and still achieve the same outcome depending on the time. The real-time MRI during an rectoplasty were available, but the most important thing is that muscle must be identified using different methods. Then screening. Remember that if a patient has a tethered cord and is not released by the neurosurgeons, that it may lead to loss of function, maybe lower limb function, or anal sphincteric function, or even urinary sphincteric function can be lost. So it's important to screen for this and treat appropriately. Then emphasis on surgical anatomy is important, depending on the type. So you need to individualize care based on the anatomy. Then objective assessment of outcome and long follow-up is important. It's important that we're hearing this so that even when these patients maybe move into adult life, they may present to the adult general surgeon. So it's important. Then quality of life assessment, I've talked about centralization of care, then multidisciplinary care, like apart from pediatric surgeons, sometimes gynecologists, urologists, even nurses, even gastroenterologists, like all these bowel management protocols is also can fall into their purview. Then, when possible, single stage procedures without colostomy can be done. But it's important that it's important to note that you do what you have experience in, and if you do a single stage procedure and you require colostomy, please go back and do it, because colostomy protects the new anus. And if there's breakdown and sepsis that may lead to destruction of the sphincters, please, it's better to do a colostomy than losing the sphincteric function due to sepsis at that site. So in conclusion, I would say that a socially acceptable anorectal function is the main aim of treatment of these patients. And until such, and every effort should be made to achieve that. And until such is achieved, the patient will not be satisfied. So we will make effort to satisfy our patients. Thank you very much.
Thank you, Professor. Thank you, Professor Ezomike, for this very interesting presentation. I think one main takeaway from there is that anytime we as adult surgeons see a patient in adult life who has had a repair of anorectal malformation and comes in with some form of bowel condition involving the anorectal region, we should always still liaise with our pediatric surgery colleagues to get advice and even co-manage the patients to rather than working in isolation. Thank you so much, sir. So, as a quick announcement before we go to the Q&A session, there is a link sent in chat box of attendance. Please kindly fill in the link if you have not done so, because it helps us with our record keeping and for data collection so that we can track our progress in terms of meetings. Thank you so much. Without further ado, I would like to hand over to our international rapporteur, Mr. Emmanuel Guare, FRCS, to handle the Q&A session. Over to you, sir.
Hello, good evening. Thanks very much, Professor Ezomike. I apologize. I think I got my time wrong today and I didn't join you at the very beginning, but just from the point I caught up with you, that was quite an interesting presentation. Thank you so much. And it's interesting to know that you're speaking from my alma mater.
Okay, you're welcome, sir.
Very, very impressive. Before we go into the questions we have on the chat site, I just wanted to ask a question about the fecaloma and the dilated anorectum you emptied. I can see that you had to suture it back. Did you reduce that into the pelvis before performing the new anus?
Okay, did I get you? Okay, what's the dilated bowel I showed was both it's like the distal part of the sigmoid colon and the rectum. So we made the incision on the sigmoid and retrieved it, but we had to like extend the operative the hand into the pelvis to milk up the part of it that was in the pelvis. Then we sutured back because there's still a protective colostomy proximally.
Yeah. My concern is with this patient, would you say was 24 years old, and from the way you described it, there was loss of the tinea coli because of the chronicity of the dilatation. Do you
Yes.
think this will ever regain function, or are you expecting it to shrink back to normal because of the defunctioning colostomy?
Okay, we are hoping that it will regain function.
All right. Okay. My instinct would have been to just excise this bit and create a
Okay, to exercise.
colostomy. Yeah.
No, she came with a colostomy already.
Okay.
She came with a colostomy already.
That's very impressive. I'm not a pediatric surgeon, but the much I can remember is Professor Nwankwo, Festus Nwankwo in UNTH.
Yes.
Okay. That's ages ago.
Yes, that is.
Yeah. So I just go through the questions on this chat site, and please, if you have questions, let's just post them there, and maybe please, can we put the full screen back, so if there are people indicating by raising up of hands, then we can see them fully. There's a question from Dr. Adeye here. It says, thank you for the presentation. I have this question. Do you think anorectal malformation should be reframed as a lifelong functional disorder rather than a childhood surgical condition? And if so, how should adult service change?
Okay, do I take them one by one, or you want to ask all the questions?
Or it might be beneficial. I think that's the first question we have there. So
Okay.
okay, all right. I see what you mean. And then the other, he also asked another question. In an adult patient presenting with constant fecal soilage following repair of anorectal malformation in infancy, what do you advise, colostomy or the MACE procedure? Yeah, those are the two questions.
Okay. Thank you, sir, for the questions. Concerning the first question, if anorectal malformation should be reframed as a lifelong disease instead of just a childhood condition, like it was made clear in the presentation, like it's a spectrum. Some anorectal malformations may be treated and the patient becomes continent in the early infancy and may not have any other problem. But for the more complex types, especially clinical anomalies, they may require more long-term care. So it may be difficult to project when the care will end in those more complex cases. So I think the emphasis on long-term follow-up and the quality of life assessment and all that is emphasized in this presentation, especially for those types of high anomalies. So I think that's what I will say. Some can be treated in the infancy or early childhood and may not have any problems in getting into the adult life. But for those that then the care should be individualized and taken as far as it can go. Then when there is fecal soilage post surgery for anorectal malformation, then one should assess and know the cause. If, like I said, in some cases is a problem with the sphincters that is not well distributed around the near, and then a reoperation may resolve that. But assuming it is maybe a very high type of anomaly with congenital, poor development of the sphincter complex, then if every other non-operative, like physiotherapy to improve the muscle function, and some bowel management protocols are all done and they fail, then the end of the spectrum is to do maybe a form of diversion. But if the malone continent, malone antigen content enema obviously is better than leaving a permanent colostomy.
Okay, thank you very much. And there's a hand symbol there from user. I don't know the name of that person. If you are the one with that user symbol, please, you can ask your question. You are muted currently. Yeah.
Good evening, Prof. Sir. Good evening, sir.
We can hear you.
Good evening.
Thank you, Prof. Sir, for please indicate your perineal fistula, sir. Thank you, sir.
Your signal is poor. Can't hear you.
Sorry, I didn't hear the question.
Ectopic anus and perineal fistula, sir. The differences. Thank you, sir.
Okay, please, can you repeat it? You didn't hear. I know that I told you I heard the ectopic anus versus I didn't hear the other part.
I think he meant ectopic anus and the perineal fistula.
Okay, so if
how to differentiate it. So a fistula doesn't have, the external opening of the fistula is not surrounded by sphincters, by the anal sphincter. So that's just the basic difference. The external openings in both cases are anteriorly displaced, but the ectopic anus has the full complement of the sphincters, and on examination, you can see the normal puckering that is associated with a normal anal opening, unlike a fistula, which is just, an external communication without a fistula. I mean, without the sphincters. So when there's a fistula, then it has to be surgically corrected so that a new anus is created through the sphincter. But if it's anteriorly displaced anus, unless there's associated maybe stenosis, then it's dilated. But if the patency is adequate, there's really no treatment for that, because it's difficult you cannot move the sphincters back to the normal position. So you leave it with the sphincters where it is. Thank you.
Thank you, sir.
Thank you so much. There's another question from Dr. Ajayi here and Dr. Arwa. I think both questions are very similar. I'll just read both. And Dr. Ajayi is asking if on the 24-year-old, it says, I would be expecting bowel dysfunction due to the ectasia. Therefore, wouldn't a tapering procedure be indicated? And Dr. Uche also asked the same question. They just want to know if tapering the dilated rectosigmoid segment to reduce the size before anastomosis will be an option for this 24-year-old patient.
Okay, thank you for that question. It's obvious that the dilatation was quite massive, and there may be some dysfunction. So, but we didn't do that. We may have considered that tapering actually is a valid option. So what we are doing now is that we are resting the area. So maybe before we close the colostomy, we may do a form of enema to assess the size. So that's what we may have to do. Thank you for pointing that out.
Okay, and just how will you assess the function prior to closing of the colostomy, the function of that ectatic dilated rectosigmoid? Is there any way you can assess that before closing the colostomy?
No, there's no direct way. We don't have any direct assessing that function, unless maybe. So we are thinking that like if we do sorry, somebody's speaking at the background.
Yeah, there's some. Okay, I think he's muted.
So if we can just assess the size. We may not have any way to assess the exact function, but maybe from working with patients with a very massively dilated colon in maybe Hirschsprung disease and all that, we have seen that though we don't have a direct way to really measure the function, that when they are rested over time, they tend to regain function.
Okay. And of interest, will anorectal manometry be of benefit here? And also, you did mention that in the course of your presentation that you use the muscle stimulation to try and identify if there is disrupted inner sphincter muscles. I was wondering,
Yes.
will you evaluate that with an endoenal ultrasound prior to surgery, or is there any way of defining the anatomy before surgery?
No, endoenal ultrasound will be useful in maybe when you want to assess the muscle wall of the rectum or maybe of the gastrointestinal tract. But in this case, what we use mainly is muscle stimulators because they is within the sphincter complex is not within the wall of the rectum itself. Okay. It's surrounding it. So that identifying or mapping them out, intraoperatively, at least will help you make sure that you pull through the muscle complex. So that's what we do.
Okay, thank you very much. Dr. Ade, you have your hand up.
Thank you, sir, for recognizing me. I just wanted to make a quick comment on how to assess function of that dilated segment of large bowel. I'm just thinking probably options that we could use if are available are things like a water-soluble contrast enema study under fluoroscopy to see the transits of the contrast as it moves in real time. The other option would have been to do an X-ray colonic transit study. Of course, the issue there is the logistics and how relevant or how reliable those tests will be. But those are the things that came to my mind in terms of assessing the function of that dilated bowel. Thank you.
Okay. Yeah, and just well, for adults, many of them, the adult patients, for you to assess those functions, they are in part of the components of the anorectal manometry is that you do the anorectal inhibitory reflex to actually see if you dilate the rectum, would there be converse or reflex anorectal muscle reflex. And the other thing you want to assess the functioning of the emptying of the rectum, because if you instill jelly-like substance into the rectum and they don't achieve evacuation, and it will be difficult for you to actually go ahead and close that colostomy because you know that rectosigmoid segment will not be functional. It might just be a very simple test to assess that, to inject this the semi or jelly into the rectum and see if the patient is going to evacuate spontaneously.
Okay.
If they can't evacuate, then that would be a problem.
Okay, thank you for that suggestion. I think we'll have to do that.
Yeah.
In addition to the maybe like Dr. Ade suggested, maybe putting if there's a contrast in it, then you now maybe take a delayed film to know if there's a residual contrast after some time. That will also help. So we'll definitely do a form of assessment by injecting some form of fluid into it and allow her to evacuate and see how efficiently that will be done.
Yeah. Thank you very much. I don't know if there are other questions. This has been a very interesting presentation, very applicable. But again, the other point that comes out here is a centralization of the practice. And I think these are complex procedures that should be done in a specialist center by somebody like Professor Ezomike, who is trained in it, rather than people dabbling into it, because most times you have just one chance, one opportunity to sort these patients out. And once somebody else has gone into that pelvis, it's almost impossible to salvage that patient in terms of function. So this would be a very good, and there are quite a lot of people. As at a point, there were 70 people on the platform. So just to take away that we should refer these patients if you are unsure, particularly if you see some unusual perianal fistula or perineal fistulas. You should have a high index of suspicion of anorectal malformation, and those patients should be referred to a specialist center for further specialist management. In the absence of any other question, I will hand over to Professor Deye to finish up and close up. Thank you very much.
Thank you very much, sir, for handling the Q&A session. It was quite stimulating and interesting. Thank you for everybody who asked questions and made comments, and for our speaker again for delivering this very interesting presentation. We do not have any major announcements, just that for us to stay tuned to our next coming meeting that will be in February, which we hope will be very interesting. In addition, Dr. Ola just returned from South Korea for his fellowship. We're giving reports of his experience there, and we'll be discussing how we can take the collaboration and other scholarship opportunities forward for the society. I again want to thank our teachers, our mentors, our colleagues, our friends. Thank you for everybody for joining this meeting and for your participation on a Sunday evening. It's not easy to take time out to do this, but your constant presence gives us encouragement to continue to forge forward ahead. And I'd like to again thank our speaker for honoring our invitation. We hope to reach out to you in due course to follow up on the outcome of this 24-year-old lady who you presented during your case presentation. Thank you so much. So I'd like to wish all of us
You're welcome.
A happy night rest and a good week ahead.